Good afternoon, everyone. Thank you for attending another Lunch and Learn session with Lavi. I'm Chris, the head of marketing, and today's webinar topic is about weight management. In particular, what does a medically guided weight management program actually involve? How medical approaches differ from standard weight loss attempts that are commonly focused on short-term results, and how does a structured team of physicians and dietitians and fitness trainers work all together to create a personalized and sustainable weight management plan? A quick intro before we get started. If you're new to Levi, Levi is a physician-led medical clinic built around precision, prevention, and personalized care with convenient locations in both Oakville and Ottawa. Levi's goal is really simple to help you stay healthier for longer so your time can be spent doing exactly what matters to you. We're excited to have Dr. Darshan Khangura back again for yet another exciting topic as we kick off the new year. Dr. Khangura is an endocrinologist specializing in diabetes and obesity medicine with academic and clinical experience in both the United States and Canada. He's American Board of Obesity Medicine certified and practices in the Greater Toronto Area. Thank you for sharing today. Dr. Kangura, now over to you to discuss what we can expect from a physician-led weight management program.
Thank you very much. I really appreciate the warm introduction. Is everybody able to see my screen okay? Chris?
It all looks good.
Oh,
Yes.
good. Okay, perfect. All right. So, Chris already did some of this introduction about the V. So this is some of the Oakville office and how it looks. Really focusing on early detection, advanced diagnostics, and optimization of health. So he already gave an introduction for me as well. So I'll just kind of move forward through that so that we can get through the meat of the presentation. So what are our objectives here today? We want to make sure that we explore what the implications of obesity are on health and why does it develop. Then we'll talk about treatment, and then we'll talk about some key messages and some of the benefits of weight management, and I'll do some introduction to the program as well. So really what we focus here on the V is making sure that we're focused on quality, not just quantity, both from my perspective as a physician, making sure that we give the highest quality of care to our patients. And that's really what drew me to joining Levi initially is how do I get the best resources, develop the best programs to deliver the highest quality of care to my patients. And then secondly, when we're talking about life, looking at longevity is the length of life and how many years a person lives, but we really want to focus on not just lifespan extension, but talking about the quality of life. So the number of years that we live in good health that are free from chronic disease or disability. So not just living longer, but to live life better for longer. So what are the implications of obesity on health and why does it develop? So obesity is really recognized as a complex, chronic, and progressive disease. So previously, the thought was that it was just lifestyle, that you're eating too much, not exercising enough, that was really the major cause of obesity. But we now have a much better understanding of the complexities, which I'll get to here in the next few slides. Also here in Canada and North America, what we see is that obesity rates are rising. So here in Canada, about 1 in every 3 Canadian adults are reported to be living with obesity. That's based on 2022 data. And then projections based on the rise of which obesity is occurring, it's estimated that about 1 in 2 Canadian adults may be living with obesity by 2035, which is now less than 10 years away here. And so we need to do something to help combat this in the community. This is kind of a busy slide, but this really kind of tells you, the overall scope and breadth at which obesity affects the body. So some of the major, important ones, from my perspective as an endocrinologist, really looking at some of the metabolic associated issues associated with diabetes or associated with obesity, which I had started out my career in endocrinology, treating. Of course, as an endocrinologist, we are, obesity specialists in the sense that, we do get training in that. I was lucky in my training at the University of Missouri that we had a very strong bariatric surgery program, as well as an obesity specialist at that time as an internal medicine doctor. And so a lot of my elective rotations were spent during my fellowship, spending time with him and really learning more about obesity medicine. And then, fortunately, when I came to Canada, I had more time to even focus on this area of interest of mine. And that is when I became American Board of Obesity Medicine certified, not because I needed to help treat obesity, but more so because I thought I would learn more and be able to help my patients better. And so, extra studying after the kids went to sleep in order to get that certification. And I do really feel like it helped me as far as my practice. So metabolic complications are diabetes, insulin resistance, metabolic syndrome, which is a collection of high blood pressure, high cholesterol, abdominal obesity, etc. Then we also have some of the gastrointestinal problems with liver disease. They keep renaming this one, but it's now called metabolic associated steatotic liver disease, also associated with hernias, acid reflux. We have increased risk of stroke and dementia associated with obesity. For the cardiovascular disease system, atherosclerosis or plaques that occur in the body, which can lead to heart attacks, high blood pressure, congestive heart failure, depression, anxiety, pulmonary problems as well, like asthma, obstructive sleep apnea, even just shortness of breath associated with obesity. Then we have other things like urinary symptoms, polycystic ovarian syndrome, which relates to irregular menstrual cycles and sometimes difficulty with fertility, low testosterone levels. We have back pain, arthritis, and then cancer is one that's not really well known, but several different types of cancer are associated with obesity, namely colorectal cancer, pancreatic cancer, breast cancer, endometrial cancer, ovarian cancer, and even thyroid cancer. So a lot of things that can be affected by obesity, which is why it's so important that we make sure that we are able to treat it effectively. So why does it occur? So appetite and body weight are really controlled by the brain. And so we have this area of the brain called the hypothalamus, which controls the eating for hunger, or those hunger centers in the brain. Then we have the mesolimbic region of the brain, which is more so related to this hedonic need for eating, or the pleasure of eating. And then we have the prefrontal cortex, or the front of the brain, which is kind of executive functioning. So this is a decision, okay, well, when should I eat, and executing that function. So all of these signals are altered in obesity, which makes people predisposed to gaining fat and becoming overweight. So many factors also now, with knowing that brain biology, there's a lot of factors that also influence that and make people more vulnerable to weight gain. So we have all of these factors. So we have genetics. There are some, monogenetic forms of obesity, which means that there are actual single genes that can be affected that cause, people to be obese. In the right, patient, I do have a program that I can do genetic screening, for free for certain patients that will, test the array of genes that are associated with obesity. There's the environment, of course. One of the things that I do usually when I'm seeing patient for the first time is talking about, what kind of medical issues might be related to obesity, what kind of medications, could be playing a role. Then there's behaviors, there's the gut microbiome, there's several factors that are also influencing obesity. So our body is really designed to defend against weight loss. So we used to be cavemen and cave women, and if we didn't keep our fat mass on throughout the winter, then we wouldn't survive, right? So the body really views weight loss as a threat. So a couple of mechanisms, which we term metabolic adaptation, will influence our body's response to weight loss. And so one of the things that happens is that the metabolism slows. So our body starts burning less calories, and then those appetite centers in the brain get signaled to increase hunger and cravings, all to defend that highest fat mass set point and try to get us to gain weight back. And so that's why we a lot of times see people gain weight after attempts to lose weight. So after each weight loss, we see that, as I mentioned, hormones, energy expenditure, even our muscles become more efficient at using energy, all in hopes to, gain that weight back so that we don't burn as many calories. So we see a lot of times this kind of yo-yo where people will lose weight only to gain more weight back, lose weight again and then gain weight. But we see that this is a kind of general trajectory over time that we see weight tend to increase. And often beyond that starting point, because if our body's burning less calories and we go back to doing similar behaviors or similar eating patterns that we did before, then we will see the weight gain come back. And a lot of times people will overshoot and actually gain even more weight than before. So how do we work on this and how do we treat obesity? So obesity is complex, and so we need to make sure that we're looking at multiple avenues that we can affect in order to help treat obesity effectively. It's not simply that we can just take a medication, although our medications are getting better and better nowadays. But we really need this framework to help get the best results. So first part at the top of the framework is really working on physical activity and medical nutrition therapy. So thankfully here at Levy, we have excellent dietitians that work with our patients to help develop personalized plans and nutrition plans and continue to work along the way, not only to just give patients a diet, right? So me as overseeing things, I tell that to the patients all the time that I don't want you to diet. We want to make sure that we're eating nutritiously. And so really focusing on things that are going to work for you. If we try eating some things and we don't like those, we have to, pivot and try to, switch our diet and really make sustainable changes to our diet in order to get long lasting results. Because a lot of times, as you saw in the previous slide, we can get effective weight loss if we do, things that are strict. But the problem is that we have to be able to stick to those things long term in order to continue to maintain that weight. And if we don't, we see weight regain. So the three pillars of obesity management really are nutrition, activity, and then we want to help see what we can do to help out with those things because it's difficult. And so we want to make sure that we are able to support people to be successful. So we have psychological and behavioral intervention in the terms of using dietitians to help change that behavior from a diet perspective. And then there's also cognitive behavioral therapy and psychotherapy that can help with the behavioral change, because behavioral change is difficult. Then we have, pharmacologic therapy, of course, a growing number of agents that are available now to help with weight loss. And then bariatric surgery used to be really the only way that we could really effectively lose significant amounts of weight, to improve health. Because our medications weren't as effective previously. But now, as we get more and more medications and understand this better, we are starting to get medications now that are almost as effective as bariatric surgery in terms of weight loss as percentages. So going back to the behavioral component, so cognitive behavioral therapy, also referred to as CBT, is this psychological approach that really emphasizes the role of thoughts and how we feel and how that relates to what we do. So we want to use that knowledge of these behaviors and thoughts to support people to make positive changes. It is a collaborative effort with the psychotherapist in order to kind of really work on and see what some of the barriers to change are and help patients work through those barriers. It has framework that we can kind of follow. It's goal setting. It's educational. Really we want to make sure that we empower patients to be able to make some of these changes. And then there's also it's based on evidence, throughout the range of emotion and behavioral problems. When it comes to medications, we have several medications that are approved for weight loss in Canada. So we really also too are recognizing that if we are going to use these earlier in the natural history of obesity, we can kind of reduce a lot of the weight related complications that tend to increase and progress over time. If you look at North America and you follow people over time, generally what we see is a slow kind of gradual weight gain over time, just because of our obesogenic environment. We are less active, we have more convenience, then we have access to not the most nutritious food, ultra processed foods, convenience, fast food, restaurants, all of these things lead to excess calorie intake typically. So as far as medications, it's got a little bit kind of a sciencey slide, and when I give lectures to family doctors, since I do that, fairly frequently, usually once or twice a month, to help, disseminate knowledge and encourage family doctors to also, treat and think about obesity management as well as, diabetes management. Tends to be a little bit, more on these slides, but I try to take things away to make it a little bit more simple. But essentially, we have three major medications that we can use for weight loss. So, one is called orlistat, which is on the right-hand side of the screen. Now, what that medication does is it inhibits the absorption of fat in the diet. So, that's one medication that we can consider. Usually not the most effective, but something that we can use. Contrave is another one. Now that one works in that kind of mesolimbic kind of reward system in the brain, is that kind of that want and that pleasure system when it comes to eating. So when I have patients that really have a hard time with cravings and certain food choices, and really this kind of pleasure side around eating, Contrave can be a fairly effective medication. It is a tablet. And so I do certainly prescribe that medication. Of course, talking about whenever I see a patient for weight management, I'm always going to try to ask a lot of questions to kind of see, where are the problem areas, and then really try to kind of make sure that we tailor therapy to hope that we get the best results by making sure that we're giving the right medication to the right patients, and of course keeping in mind baseline medical conditions, side effects, all of these things we want to take a look at. But Contrave is a tablet approved for weight loss in Canada, and it works in that mesolimbic or reward kind of pleasure area, and for cravings, in the body and in the brain. The other part is the hypothalamus. And that area, as I mentioned, was kind of the area which also is involved in appetite regulation. And so we have medications which I'm sure most people have heard of nowadays because they're very popular on social media, and they're kind of everywhere. But these are these GLP-1 receptor agonist medications. So the GLP-1 is a hormone that is naturally occurring in our body. It is produced by the gut in response to food. So when we eat a meal, then we start to digest, and then our gut will start to release certain hormones, of which is GLP-1, and there's another hormone called GIP as well. And so these hormones are called the incretin hormones, or the gut hormones, and they also have impacts on several different tissues and parts of the brain. And so there's two called Saxenda and Wegovy. Saxenda is a little bit of an older medication. It is an injection. It's once a day injection. And so that was one of the kind of earlier GLP-1s that had came out. Still available, not used quite as much anymore. Daily injection versus weekly injection. Most of the patients would prefer to do once weekly injections, and the weekly injections tend to be a little bit stronger. So the brand name of semaglutide, a lot of people probably have heard of Ozempic. So Ozempic is the GLP-1 receptor agonist. That is the diabetes version of semaglutide, which is the generic name. Wegovy is the brand name version of semaglutide, which is branded for obesity management, and it goes to a little bit higher dose than the diabetes version. Saxenda also had a diabetes version that was not really used very much anymore, called Victoza. But these medications are these GLP-1 medications. So what they do is they decrease appetite centers in the brain, so tell you to eat less. Also has effects on the stomach itself, delaying or slowing gastric emptying, making people feel full longer and full faster than they would otherwise. Zepbound is the newest, most potent weight loss medication we have. Some of you may have heard of that medication called Mounjaro. So Mounjaro, again, is the diabetes version. Zepbound would be the weight loss version, and it has that dual hormone receptor action. That extra hormone does tend to make the SG or the GLP-1 even potentiated effects, and then also does have some effects in the brain, actually decreasing nausea, which is one of the major side effects of these medications. And then also, in addition, has some direct effect on adipose tissue, or the fat cells themselves, increasing insulin sensitivity, leading to better results typically with that medication, compared to the others. Bariatric surgery, I'm not going to go in too much detail for this, but I just kind of wanted to introduce some of the things. Gastric band is something that was popular a long time ago. Not really doing a lot of gastric bands anymore. The band would sometimes kind of erode and damage the gastric tissue and cause ulcers and issues. Also, sometimes the band would slip and cause other issues. So gastric band is not really done a lot anymore. One of the newer procedures that has been popular and being done a little bit more is the vertical sleeve gastrectomy, which is down in the bottom left-hand corner. So what this is they essentially will staple a good portion of the stomach, and kind of making the stomach, instead of being this kind of sack or water bottle like structure, into more of like a banana. And so, of course, can't hold as much food in the stomach. Does kind of more rapidly empty into the intestines, and is restrictive and slightly malabsorptive, but not as malabsorptive as the Roux-en-Y gastric bypass or gastric bypass that you may have heard of, where it's more commonly referred to as. So that's up in the top right hand corner. So what you're taking is a stomach and turning it into a small pouch, which is restrictive. And then you're also bypassing part of the small intestine, or the first part of the small intestine, called the duodenum, which a lot of nutrients and vitamins are absorbed. And so when doing gastric bypass surgery or even the sleeve gastrectomy, we recommend vitamins and make sure that we are not going to be having any nutritional deficiencies as a result. In the bottom right is the most aggressive bariatric surgery approach to weight loss. That's called the duodenal switch surgery. So you're going to bypass a lot more of those small intestines in this case. A lot more nutritional deficiencies can occur with this one, but that's the kind of most aggressive form of bariatric surgery. So what are some of the key principles that we want to talk about? Another thing that I always talk about is that with my patients is that it's not just about weight. It's not just about the number on the scale. Really, we want to make sure that we're focusing on health. And in order to do that, one weight might not be good, for a patient, but might be good for another. So we really want to make sure that we individualize our treatment. There is no single ideal weight. Some of my patients say, well, what would be the best weight for me, for my age or for my height? There really isn't, a single best weight that we want to look for. Really it ultimately depends on, each patient. What weight are our patients most comfortable at? There are certainly different cultural aspects to this. Some cultures, don't want to lose too much weight, either. So end of the day, we want to personalize our treatment goals, and take into account person's health status, lifestyle, and their preferences. It has to be also sustainable and realistic to maintain long term. So that's very important. We're not just looking at a specific number for BMI, et cetera. Really, we want to make sure that we lose the appropriate amount of weight for that patient. As I mentioned, really should be health-centered, not weight-centered. We really just want to improve health outcomes rather than reaching that specific number on the scale. And then in addition to that, we want to, of course, be supporting mental, emotional well-being. So that's really where, we can have, appropriate allied health professionals involved. We want to make sure that we're focusing on becoming more healthy and not develop like disordered eating and other issues that can lead to depression and other mental health issues, anxiety, all of these things. So we want to make sure we get to the best weight without sacrificing enjoyment, food, physical activity, and health. So when it comes to nutrition, I'll just share some key, points. Of course, we go into a lot more detail, as a part of, medical visits and dietary visits, and as a part of the program. But we want to make sure that we're eating a variety of healthy foods every day. We can't just eat the same thing every day. It gets boring. We can't be boring. We need to make sure that we're still enjoying our food, and doing things in a sustainable way. We want to limit these highly processed foods. Eat them less often. We still have to live life though. So sometimes you're going to be in situations where, this is the only food available. So we just want to make sure that we kind of pick and choose within those foods, and only eat small amounts, and certainly do it less often. Make sure that we're eating slowly. Make sure we're, keep in mind our hunger cues and our satiety, cues. Making sure that we're choosing healthier options when we're eating out. Limiting alcohol, making sure that we try to make water our drink of choice, and replacing sugary drinks. Ensuring adequate protein is very important to help us maintain our muscle mass and lose the right type of weight. That's where really body composition analysis and frequent follow-up really help us make sure that we're losing the right type of weight, especially if patients are taking medications. Sometimes the medicines are very strong and people will not, feel very hungry. So we want to make sure that we're eating the right things. Can use some of these handy portion guides as well. Physical activity is very important. Not really for weight loss, but more for the weight maintenance and for overall health. So we want to try to get about 150 minutes a week. A lot of times people look at that 10,000 steps a day. That number was kind of made up, when it came to these fitness trackers. Really there is some data behind 7,000 steps a day is probably associated with major health benefits. If you're not active now, that's okay. Start small, even 10 minutes at a time, standing more than walking, stretching. These are all things that are going to help you progress towards continuing to lead healthier, more active lives. 2 to 3 sessions a week of resistance training or strength training really helps promote protection of the joints, protects muscle, boost energy. So we do want to focus on some resistance or strength training. Make sure this is a very important one. I always tell my patients all the time. We need to choose activities that we enjoy. If you enjoy it, you'll continue to do it. If you hate it, you can do it for a little while, but that's not going to be something that we can stick. So we always got to make sure that we're making choices, whether that be dietary choices or activity choices, that is something that we actually like to do. Then it doesn't feel like a chore. Technology can be helpful, to help support your goals. And don't worry about the scale. It's not only the scale. Sometimes weight doesn't change, but we get body composition changes. And that's actually better than just seeing weight loss. What about the health benefits? So I'm always usually trying to shoot for, we should try to get about 10 to 15% weight loss, ideally if we can, of body weight to improve cardiovascular disease, that the liver disease that I was talking about, acid reflux, osteoarthritis. Even 5% weight loss still has benefit for blood sugars and blood pressure. If we're looking at 5 to 10%, we see cholesterol improve, type 2 diabetes, can be prevented. If we get even more weight loss, more than 15%, then we're starting to see even remission, or we get rid of diabetes, improve cardiovascular disease mortality or cause of death from cardiovascular disease, and even heart failure. So even a little bit goes a long way in terms of improving health. So here in the V, I'm the physician lead of the weight management program and help develop it. So medical evaluation with me, the endocrinologist, is a big part of the program. Me overseeing the whole program. In the initial visits, they're more frequent, like every 4 weeks for the first 4 visits, so that we make sure that we're getting on the right path and making positive change towards improving health. Once we kind of get into a little bit of a rhythm, then we start to increase those visits to every 3 months. There is a comprehensive health assessment. We're going to do blood work to check on all metabolic components associated with health and some of these complications that we can see associated with obesity. DEXA body composition, that's the gold standard for body composition. We also have a bioelectric impedance scale that we're going to do more frequently too, to check on the body composition changes. Continuing to have oversight. And then my involvement is to adjust medications, monitor progress, ensure that we're optimizing health throughout the journey. We do have the dietitian involved for the personalized nutrition plan. We have nutrigenomic testing as well, which is looking at genetic predispositions to certain food sensitivities or certain vitamin deficiencies, all to make sure that we're getting a customized, plan, for the patients. We're going to have multiple check-ins. And then we're going to track all these key metrics to make sure that we're getting results that are consistent and sustainable. So I hope everybody enjoyed that talk. I know that there was a lot to get through and I went a little bit fast, but please, I'd like to open up the floor to any questions that anybody might have.
Thank you very much for an incredibly insightful discussion, Dr. Khangura. As Dr. Khangura mentioned, we'll now open it up to Q&A. You should see a little Q&A box at the bottom of your screen, so feel free to enter any of your questions. I do see a question from Jessica here. Jessica is asking, are medications like GLP-1s meant to be short-term or long-term? And she's also wondering what are the most common side effects and how they're monitored.
Great question. So generally what we see most of the time in most of the literature and the studies when it comes to weight management with the GLP-1 receptor agonist class of medications is that we see that when we do stop the medications, for most patients, there is a tendency to see weight regain. And so the thought is that obesity is a chronic disease, much like blood pressure, cholesterol, diabetes, in the sense that we may need to keep medications on board long term to help sustain that weight loss. Now, I will say, though, however, that in my experience, I have had some success in stopping medications for people and having them maintain their weight loss. Now, those are the patients that have really used the medication as a springboard to help make some significant, changes to dietary habits as well as exercise habits. But in the studies, we see mostly, people having some weight regain. Although there was an article that came out recently that I saw that showing that real world data in the U.S. Showed that more people than what we saw in the studies are actually able to probably maintain their weight loss and come off the medications. But ultimately that is quite an individualized approach. Usually in my practice, if we help people lose weight with the use of the medications, I'm really going to focus on, once they've kind of got to their goal weight, at focusing on making the appropriate changes and be successful with the appropriate changes to be most successful in keeping that weight off. And only then I say, okay, hey, let's start to try to wean off this medication. Some people do great with that. Most will start to have a little bit of weight regain, and sometimes maybe a lower dose perhaps can be used as more of a maintenance dose, or maybe even de-escalating therapy to something different that might help with weight maintenance as well.
Great. Thank you very much for that detailed answer, Dr. Khangura. I have another question here from an anonymous attendee. They're wondering, they're asking, I have a slow metabolism. How difficult is it for me to increase it? And I have tried dieting, which did not work.
Yeah, metabolism is something that's kind of complicated, right? So, first part of my evaluation usually is to make sure that we're not missing anything metabolically that is holding patients back. There are medical conditions that do affect metabolism and make it more difficult to lose weight. So we always want to make sure that we're making sure that we check into those, and if some of those are present or undiagnosed, that we go ahead and treat those to kind of get rid of some of those hurdles. It's difficult enough to lose weight. We don't want anything medically holding people back. Now, I wish I had like a metabolism pill. If I did have a medication that hopefully I would be one of the people who helped develop that one, and then I could sit on the beach and collect my checks and not practice medicine. However, I do truly like what I do, so even if it wasn't that instance, I would still practice medicine, but maybe just not 5 days a week. But unfortunately, we do not have anything that necessarily improves metabolism. But that's where sometimes if we've done everything that we can do from a diet and lifestyle perspective, sometimes we need some help, for the weight loss. And that's where some of the medications, really come in. And thankfully, we're in a position now where we do have actually quite effective medications to help us. But ultimately, it's always hard to say without having that full evaluation.
Right. Thank you. And I have one last question here from Bill. Bill is wondering, Dr. Kangura, I presently have been using Ozempic for about a year and a half, as prescribed by a doctor in your office. I use it for only for weight loss, not for diabetes, but I do have sleep apnea. Would changing to Zepbound be better for weight loss and sleep apnea?
So yeah, Zepbound is certainly a little bit stronger when it comes to weight loss. So I will sometimes have or encounter patients that have been using semaglutide, whether that be Ozempic or Wegovy, for weight management, and have kind of gotten what we kind of expect out of the medication. Some people do a little bit better, some people do kind of worse than what we see on average in the studies as far as weight loss. And so I have escalated therapy to use the stronger medication, which is Zepbound in some instances, and got more weight loss associated with it. And so really we need kind of those higher end weight loss numbers to get rid of obstructive sleep apnea. So sometimes we can actually resolve of sleep apnea with significant weight loss. Now, I get kind of mixed responses to that. Sometimes when we switch over, people do really excellent, and it does help a lot more. I think that I want to just highlight the fact that everybody's different, and so sometimes we see really great results with one medication for one patient, but then another patient might not see the same response. So it is worth sometimes a thought to make a change. There's also higher dose semaglutide than Ozempic, like Wegovy, for example, that could be considered as well. And there's a whole pipeline of new medications that are going to be coming out in the years that are kind of in all the clinical trials in phase 3 in clinical testing in the real world right now. So, we'll have more and more options available to us here in the future.
Thank you very much, Dr. Khangura. And that concludes today's webinar. If you have any further questions, feel free to email us at info@levyhealth.com, or you can always fill out the patient advisor form on our website at levyhealth.com, and we would be more than happy to answer any other questions you may have. We will also be sending out a recording of today's presentation that'll probably go out tomorrow, so just keep an eye out for that. And yeah, that concludes today's webinar. Thank you everyone so much for tuning in, and thank you, Dr. Khangura, for providing such an amazing session.
Thank you so much.
Thank you.